My name is Andrew Corrin. I'm a general practitioner, primary care specialist in Tauranga. The GINA Guidelines for 2019 have changed substantially. Some have said that it's the most fundamental change to the guidelines in the last 30 years. Why have they changed?
I do believe the changes in the 2019 GINA strategy update are quite revolutionary.
So the GINA guidelines have changed because there's now convincing evidence that an ICS formoterol combination inhaler used as a reliever therapy seriously outperforms a short-acting beta agonist or a SABA as reliever therapy across the spectrum of asthma severity.
It's taken us a long time to learn. We must be slow learners. That patients do not like taking a regular daily preventer medication. On the other hand, we've known for a long time that SABA alone, as reliever, is not good for asthma.
It really reflects back what we've been saying for a very long time about asthma and the importance of asthma as being a chronic condition, which is present not just when people have symptoms, but really is present in the background with inflammation, and the critical role for using preventer treatment to suppress that inflammation and prevent serious symptoms and serious consequences of having asthma, even in people with the mildest of disease.
So what are the changes to the GINA 2019 guidelines?
The GINA 2019 update now recommend that across the spectrum of asthma severity, that ICS formoterol combination inhaler taken as a reliever is preferred to a SABA as a reliever therapy.
The GINA guidelines, so the international guidelines, now recommend as the preferred approach the use of an inhaled corticosteroid and formoterol combination as needed as step 1 and going into step 2 for the management of asthma, and indeed as the reliever medication across the board, even for higher steps in moderate asthma.
And I think the biggest changes really come in step 1 and step 2. We've known for some time that ICS formoterol as a reliever therapy, when taken together with maintenance ICS-LABA, seriously outperforms SABA reliever therapy with the same maintenance treatment. But I think the recent evidence has shown that compared in terms of SABA monotherapy, that ICS formoterol seriously outperforms SABA monotherapy at that early stage of mild and intermittent asthma.
The importance of this is that the formoterol is a rapid onset bronchodilator. It's a long-acting bronchodilator, but very rapid in onset, equivalent to salbutamol.
We hear about risks associated with ICS or inhaled corticosteroids. What are these risks, or are there risks, particularly in patients with intermittent or mild asthma?
Patients are titrating the dose according to their need, and so they're actually taking the lowest dose that is possible in terms of achieving a good outcome. So in fact, in the studies that have looked at this therapy, the ICS formoterol therapy in mild and intermittent asthma, the patients are only taking 1 puff every 2 to 3 days, which is actually a really low inhaled corticosteroid dose. And considerably less than the dose they would be taking in terms of maintenance ICS therapy. So I think in some respects, the ICS formoterol reliever therapy regime in mild and intermittent asthma will lead to less inhaled steroid dose than the alternative of maintenance inhaled corticosteroids, which is the other recommended option for these patients. So in fact, it is an advantage or a strength of this therapeutic approach.
Guidelines need to be continuously reviewed and updated where evidence provides sufficient challenge to the existing paradigm. The 2019 GINA Guidelines have addressed the latest evidence with respect to patients with mild asthma, and I think that they have presented us with a very important moment to change our behaviour as clinicians for the benefit of our patients with mild asthma.